Basically what we're doing is, it's kind of a brief chat. It's nothing expressing any other opinions than ours.
Absolutely.
Talking about TRI conference and about research, the state of research, how things can move forward and such.
Yeah, and just to be clear, like Steve said, I think this is just really, we're just looking to shoot the breeze a bit about what's out there, what our thoughts are on the latest research, because both Steve and I have attended the main Tinnitus conference this year, and just really hopefully introduce some new ideas as well, and just give our own takes on where the field's at the moment.
Yeah, so I guess if we start TRI.
Yeah.
It was a while ago.
March, I think.
Yeah. And for clarity, it's now November.
Yeah.
Well, only just coming into December. So I have the memory of a goldfish. So I kind of remember bits of it, and it's the standout bits I get, which you've probably got a lot better memory than I have.
Well, we'll see. But yeah, I mean, overall, I thought the conference was quite neatly done, because there was a lot of new people giving keynotes, which was really exciting. It wasn't the same old crowd, really, the sort of people you'd expect, and that gave the conference a nice feel. I think it did make you think that there were sort of emerging researchers that had something new to say, and that was really positive.
Yeah, I thought that as well. I think there were some of the usual suspects there.
They're still there.
Yeah, which is good, I guess, because you want to see the people who've been in the field for a lot of years actually keeping the knowledge up to date and mixing with the people who are brand new in the field as well. Yeah.
So, I mean, from that, I mean, you said, the things you remember, the bits that really stand out for you. I mean, what were they?
I guess for me, Will Sedley stood out above everything else, because his research is just like, wow. I was just saying to sit back and just think, that's great, that. And it kind of resonates. I won't pretend that I understood more than probably about 25% of it. But
Yeah, absolutely. I mean, I've known Will for a while, so I kind of knew what he was presenting, but at the same time, it's always good to have that wash over you again and just try and see new elements of it. And I think out of the new crop, it's first of all, it's great to see a neuroscientist involved, because that's not every day that you've got that type of level of scientist that's interested in tinnitus. But as well, he's really kind of starting to push the boundaries and is presenting a very new and novel idea for what tinnitus might be and what the model is. And I think that's refreshing to see, because whilst we still don't have that one agreed upon model, actually Will's makes a lot of sense, because he's looking to tie a lot of different ones together almost as well.
Yeah, and I think the thing for me, you look at the idea of prediction model, and it kind of, the neurophysiological model makes sense. It's like, you hear it, you go, what the hell's that? And then you kind of process it in such a way, but it doesn't explain why you continue to hear it. And it doesn't explain why, when you tackle the reaction, it stays. It's kind of like, it throws a lot of things out there, but it doesn't answer all the questions. Whereas the prediction model, taking it to a brain level, it's like, so that's the cognitive processes happening behind, which would explain why, if I feel as though that, I consider myself habituated, but I can't get rid of the bloody noise. It's got louder over the years. So you think, well, if I'm habituated and I've learned to deal with the reaction, why? And the prediction model kind of explains that to me, and it really resonates. And it kind of, afterwards I was just kind of like thinking of different ways that you can try and interrupt tinnitus, and what can you do to treat it? How can you actually deal with it in the prediction model? And for me, it kind of opened my eyes quite a lot.
Yeah, and I think the exciting thing is now how Will's using that. So obviously it's still a theoretical model, he needs to prove it. But also looking at how we might be able to develop an objective model based, or objective measure based on that's really interesting as well. So I think for me, Will Sedley's research is very much a sort of watch this space and see where he takes it next. But he's certainly a very exciting researcher, and one that is great to have in the field at the moment.
Definitely.
Yeah, I think one of the other interesting areas for me was the research that Sarah Michelle's presented on somatic tinnitus. Because especially in the UK, somatic tinnitus isn't really given a high level of attention. It's not something that you have a separate treatment or management protocol for, which was what Sarah was presenting. And that was really interesting, because then we're introducing the idea of potentially another subtype of tinnitus based on that as well, which I thought was interesting to see. And looking at the approaches and what Sarah was using around physiotherapy to address that was really, really interesting.
Yeah, I really like Sarah's research as well, because from a selfish point of view, I've got a big somatic element to mine. From a jaw injury that I had on a construction site many years ago, and it kind of all fits in a bit. And the great thing is as well, she was able to use some of the research that we did with Tinnitus Hub, and following on from that, we have actually got an upcoming research project looking at now we've actually got the measures of somatic tinnitus to actually ask people, do they have any of these identifiers, and then trying to kind of profile it in the patient population. And let's say it's an emerging area, and you talk to anybody with tinnitus, and they've always got tension problems. There's always something in the neck or something in the jaw or something there. Even if it's not somatic tinnitus, there's so often you look and think there's got to be a somatic component to it. And if you can treat the somatic component, then you can help a lot of people. It might not be a cure, it could be for some.
Yeah.
But it's going to really help, because if I knew how to treat my somatic component, I did actually a couple of emails with Sarah recently. I was asking her about Botox, saying, could you actually Botox? And as she quite rightly pointed out, you have to get the dosage about right, because if you do it in the jaw, people lose the ability to eat and speak. So that's a little bit of a...
It's not without risk.
Yeah, exactly. I was like, well, what about sort of, for me, I know it comes from the shoulder blade as well and up the neck, and said, again, people won't be able to hold their head up if you get it too heavy. So there's a real balance to be had from that perspective of the somatic tinnitus.
Yeah, and so for me that was like I say, interesting, because it's just not an area that's really considered outside of some areas of Europe, I think, really. So it was good to see, and again, I hope Sarah stays involved in the research field really, and looks at how to develop that work, because like I say, it could be a real potential to look at as a subtype, and there's all sorts of different approaches beyond physiotherapy as well that might help there, which is exciting, I think.
Oh, absolutely,
yeah. And then another big one for me was Hubert Lim's talk, where he started to almost lay the ground, if you like, for the Neuromod device that we know is up and coming. So he was talking about how using bimodal stimulation really has an impact on tinnitus, and sort of set up the talk, the industry talk that Neuromod gave later on in the conference as well. So again, that was really enlightening, really.
Yeah, I think, and that in parallel to sort of the, unfortunately Susan Shaw couldn't make it, but to a couple of her students or collaborators, I don't know what they were actually, but they explained again their model and their thing, and it was quite, that side of it really grabbed us as well, because it's new emerging research, isn't it? And it's something which, again, makes perfect sense in the sort of the neuromod as they've been presenting recently, the idea of priming the brain. The idea of sort of saying, okay, well, here we've got this sound which may or may not help people or whatever, but then if you prime the brain, you get in there and kind of push the right buttons inside there that you actually make the brain listen to it and make it pay attention, and then increase the efficacy of the treatment. Yeah,
and it's really interesting. I think they've got two groups coming up with very similar ways to look at that, both with slightly different protocols, because they're looking at that, both using sound as a sensory input, of course, but then looking at a slightly different nerve stimulation to get that sort of bypassing the auditory pathways, or to get the auditory pathways more active. But really interesting to watch how those two emerge, really, and almost compete, I guess, to see who can get it out there and which one has the best efficacy. It'll be really exciting to see.
Yeah. Well, the competition to get it out there looks like it's quite...
it's a little one-sided. But nonetheless, I think it's it'd be really interesting to see what Sue Shaw's team does next, and where that work goes as well. And hopefully hear it presented as well, because I think that is a challenge at the moment. Is you can read the papers, but for me it's seeing it presented. You really get a much better idea, and the context of it's interesting as well.
Well, the presentation they did at TRI, I thought was it kind of made it like, wow, this is pretty cool. And they showed some really good results, but of course they can't go into detail. It's still work in progress. It's still things that are being analysed. So it was kind of a window into it. And I think the session that they had as well was cut a little bit shorter. So it was I think they just had so much information to present. It was impossible to fit it into a session. It was you just wanted to kind of almost have half a day on that.
Yeah, it was frustrating because that was a really big emerging area, and you thought, let's really understand this a little bit more than we did. So that was interesting, I think.
Yeah.
And also, another sort of one of the smaller talks was on a drug that may provide a residual inhibition as well for tinnitus, which I thought was a really interesting concept. And it was frustrating because it had been shown in an animal model, I think, but the team that was presenting it really didn't have the clinical expertise to look at how to translate that into a clinical model or run an RCT. But again, it was another interesting insight that you think, well, that's got potential if you can even find a drug that does do that residual inhibition. What's the model that's making that happen? Because that's something worth further exploration. Of course, B, at least has the potential to give temporary respite as well. So again, that was an interesting talk as well that I thought was another one of those that's happening that I certainly had no awareness of, and it's good to find out more about.
And I think that kind of leads on to thinking about as well the lack of presence from pharma. Yeah. Which was quite striking because you really want the pharmaceuticals to be involved and to be there and interested in the whole thing. I mean, it's not to say that they're not, but it's the biggest tinnitus conference pretty much. I'm sure our American brothers and sisters might disagree with that, but
and I think it is it's sold the Tinnitus Research Initiative as an international tinnitus conference, and I think it should be looking to have that input from pharma. And at the moment, there are a few niche players, if you like, or some of the players that are really involved in tinnitus that were there. But overall, it wasn't really clear. And of course, can't remember if it's Auris or the other one were meant to be there, but withdrew the presentation because they withdrew the drug on the day. Was it a Tiffany or Auris? I can't remember. It was one of those two. So there are involvement there, but the big players aren't there. And I think that points to some of the other frustrations with TRI at the moment is that a lot of the trials that are presented are quite small scale. You don't see the big trials, you don't really see RCTs that frequently in tinnitus, and also that kind of leads to that model of one where I said about the residual inhibition, that there's no real translational research happening that often where you're looking at, okay, so we've done this how do we get it to market, and how do we do it as rapidly, which is why you see something like Neuromod, and it's quite refreshing because they really have that focus on the market. But then the disadvantages of that they may well be bringing something out before you've got the published research to demonstrate efficacy. So you've always got that sort of push and pull, I think, with the research.
Yeah, and then that's from the patient perspective. We all want things to come out straight away, but equally, we don't want them to come out without proper research. There's a constant sort of a balance between the two. And you say, I think the first launch, for example, the Neuromod was too soon. And and then they've come back and they've done the research, but then of course you can't win because people are complaining it's not on the market.
Yeah, why isn't it there?
So you've got that balance to find all the time, and it's really hard. I don't envy them at all.
No, not at all. And I think we saw some of the challenges because both you and I sat in the Q&A panel. You were on the panel. And one of the questions put out was, well, how do we engage with pharma, and what do pharma want from the tinnitus world? And I think that was a little bit concerning to hear, really, from TRI, because from my perspective, I think there's been quite a lot of discussion, especially from some of the pharmaceutical companies who've had drugs that have failed, about what needs to happen for them to engage more, and what needs to happen for them to really start to invest in tinnitus research. So I think we know some of that, and it was a little bit concerning, really, that the types of research that we know they want to be able to then move on wasn't really present. So when I'm talking about that, Action on Hearing Loss had an excellent conference called the Translational Research in Hearing Conference a couple of weeks after TRI, I think, and there they had engagement from pharma worldwide, and it wasn't just on tinnitus, it was on hearing much more broadly, but a couple of the big tinnitus trials presented, and actually what was interesting from that wasn't just what's coming, but just learning those lessons. And for the first time, a few of the drugs companies who've had trials were really talking about, well, why did it go wrong, and what needs to change, and the messages were coming out loud and clear, really. One was around animal modelling.
Yeah.
So there was a big belief that actually maybe for tinnitus the animal models aren't ideal, because all of the drugs that went to human trials showed great success in an animal model. So actually, is there something we can do there to either improve the animal modelling, or should we be looking at humanising the model, which was an interesting thought. Can we use human tissues somehow in that basic size to look at improving it? And so that was a really interesting point one of the presenters made. But then they're also looking at, well, can we develop that objective measure, which, as you know, is something I've been banging on about for years. But,
well, me as well. And you kind of, you're in that position of, if you haven't got an objective measure, how do you know? What questionnaire do you use? And I think another thing at your conference recently, BTA conference, Dave Bagley said in his talk about that, of like, the questionnaires are just asking you, how terrible is your tinnitus? How bad is it? They're very sort of negative and leading things, and are they really the best measures? You know, because the best, almost like you would say for a patient perspective, the best measure is, do you feel better? Is your tinnitus quieter? And it's that personal thing, but of course it's not clinically validated.
No, I think that's one of the skews. So, you know, a lot of the questionnaires that are out there now have been developed for use in research. But they don't necessarily help, because they don't give you that outcome. And actually, I was talking to one of the researchers who really does a lot of work with the questionnaires, and said, actually, given the questionnaires that we've out there at the moment, if we did cure tinnitus, would it show on a questionnaire as 0, or would you actually still score something? And the belief was you'd probably still score something, just because of how some of it's phrased. Like you say, it is almost that, how awful is your tinnitus stuff. And so actually, you know, that need for an objective measure is really refreshing to hear pharma say the same thing, that, you know, until we have that way to check how to, if tinnitus is present or not, without, like you say, someone filling in a questionnaire, then, you know, it's tough to see how you move on with some of the drugs research, I think, personally. Anyway, like I said before, this is personal opinions. And so, something I really want to push for more is, how we get that research to see if an objective measure is possible. You know, and I mean, I realise, you know, not everyone might know what we mean by objective measure. So an objective measure in tinnitus might be, you could do a blood test that shows if tinnitus is present or not. You may be able to do a brain scan, so an fMRI scan or an MRI scan that shows if it's there or not. There's different tools we could use to objectively say, yes, tinnitus is present, or no, it's not. And I think that should be a real focus of research over the next sort of period of time, as well as looking to improve the subjective measures we have, but to do that. And the other areas that pharma identified as challenges to doing future research was around subtyping as well. So a little bit like we said about somatic tinnitus earlier. Is there a way that we can better subtype tinnitus? And actually, in a few of the trials that were presented at TRI, we saw people starting to play with their data to see if they could develop subtyping as well.
And you do wonder as well in the trials, are they gathering enough information to actually subtype it? The kind of, we do have some standard measures, some standard questionnaires. I think one thing as well, you think, is there a value to adding additional questions? Like, you know, as in the masking level. I know we've got minimum masking levels, but actually asking a person, well, how is it now if you're in this social situation or in that situation? Do you still hear it? And kind of trying to gauge different ways of actually measuring the tinnitus in the person. But again, taking it back to the person. But the subtype, and there's so many things that you can look at. As you know, it took me probably about 7 years before I actually realised I had 2 more causes to add to the original diagnosis of a sort of slight hearing loss. And you can pick up these things, and it wouldn't necessarily get picked up in a questionnaire or in an interview. You'd have to be quite in depth. You'd have to really interview somebody and ask a lot of questions to try and understand if there'd been an acoustic trauma at some point, or a jaw trauma or a neck trauma, because people don't necessarily, if they're filling out a questionnaire, they're just going, no, that's never happened, no. But if you drill into it, you'll find out, well, oh yeah, 5 years ago I had this ear infection. Yeah, but that's got nothing to do with it because I didn't get tinnitus. And all these things that could have actually played a part in it, that's where it starts getting very expensive as well.
And the cause of tinnitus might only be one way to subtype. And it might not be the ideal way. I mean, that's the challenge is, you know, you could, of course, do what you're saying. You could look at subtype by cause, or you could look at subtype by severity, or there's lots of different ways that you could subtype, and it's almost the challenge is where do you start a little bit, and how do you start? Because obviously as soon as you start subtyping, then trials get more expensive because you need more groups of patients for each one. And the reason I think it's so important is when you see some of the data presented, you often see the charts and will show individual patients, and you see some absolutely fly and just, their tinnitus scores just go off the charts and they improve dramatically. You see others that go nowhere, and you see some that get worse. And so, if you could figure out, well, that group who have really improved with this particular treatment, can we figure out are there any characteristics that are the same? And likewise, are there any characteristics for the group that have got worse? And could we start to understand that a little bit better? And I think we're seeing that emerging, but I certainly don't think it's there yet.
No, like if you can pick out those things, there's nothing to say that actually for a reasonable amount of people there isn't an actual cure right now. You might be able to hit with 3, 4, 5 different strategies and knock the tinnitus in so many different ways that you can actually kill it off. Kill it off. So we don't have that at all. And again, the limitations of a clinical trial, they are testing one thing. And if they test more than one thing, it throws so many variables in the mix that it's very difficult to measure. So it's a kind of catch-22. You can't step beyond it. You could do it, as a complete experiment, but you're not really going to get anybody standing behind it because a lot of money will be involved, a lot of variables involved, and the outcomes are just, who knows?
So, I mean, we're talking a lot about the challenges to pharma in engaging with it, but the other side of the coin as well is that they are engaged, possibly not as well as they should be through groups like the TRI, but there are pharmaceutical companies out there and therapeutic companies that are looking at tinnitus. And what really surprised me at the Action on Hearing Loss conference was just speaking to some of them, outside of tinnitus and just in hearing loss generally. They understand where the field's at, and they are keeping an active watch on what's happening. And I think at the moment it might almost be opportunist in terms of, they find a drug that through serendipity seems to be curing someone's tinnitus as well, rather than, really looking for the formula, because we don't have those biomarkers and those targets at the moment. So a lot of it is opportunist, if you like. But they're definitely involved, and they understand the potential of the market, if you want to put it in those terms as well, and the potential of how big the market is, especially in the US.
It's huge if you can get it right. I mean, the cynic in me always thinks that it would end up being a sort of pill that they could sell, because if they find something that just knocks it out straight away, they're not going to make so much money out of it. But yes, that's the cynic. But I haven't read a lot about Big Pharma.
Well, actually, I mean, I talked about that with someone who was representing Big Pharma at the time, and what they said was that that is the case in terms of if you've got someone on a drug for life, then obviously there's benefits to a drug company, but actually that's really, really expensive for them to trial, because you've got to do long-term safety profiles on it, which are incredibly expensive. So actually, if they did have a drug that obliterated tinnitus, then actually that may well be more cost efficient for them, because you don't have to go through all that safety profiling for the drug to prove its long-term safety as well.
It's quite interesting, that.
So it's a different angle on it that I'd certainly not thought of.
No, and I think again that it shows that I think pharma don't necessarily engage, because things like that are really useful to the community as a whole to actually get an understanding of it. And it feels like pharma just don't have that level of engagement. They're kind of locked away in an ivory tower, if you like. You don't really see or hear an awful lot from them.
I think some of that's true in terms of they don't necessarily engage at this level, but it's in a way, whilst it's exciting for the community to understand and have that access, it's tough to see what's in it for the company a little bit, because they obviously have a compound that they're trying to protect, and they'll want to do trials on at some point. So it's until they're at a stage where they're almost at that sort of late phase 3, phase 4 trials, it's hard to see why, what's in it for them really to really have that level of publicity. But talking about that, I mean, like I said, we've said some of the negatives, but there are some really exciting things happening with pharma as well, and I think it's worth sort of highlighting them a little bit. So one I learned about at TRIH, the Action on Hearing Loss conference, was autonomy. So they're a US-based drugs company. I think they've done a lot of work around many years, and they've got a drugs compound that they're looking to do trials in the US in early 2019 as well. So that's really exciting. I think it'll be interesting to see what comes of that. I don't know a lot about it. I'm sure there's a strand on the forum about it, but yeah, it's hard to quite understand what's happening with that. But again, that looks exciting.
Yeah, well, it is. And Scott, crossing over into the unfortunately, Tinnitus didn't win the Frontiers project, which was a shame. But it was won by it was a balance disorders, which was quite interesting because it kind of seemed to be suggesting about novel intervention, about actually finding a way to cure balance disorders. So, whereas it was a big disappointment because there was a lot of effort, a lot of community effort put into getting the altmetrics and actually disseminating the research, it's quite nice to actually have something which is related, and you would like to think there'd be some translational research from that area into tinnitus as well, especially with drug development, because if you're targeting that area, then
yeah, so, and like I said, autonomy is one. I mean, Pragma Therapeutics are looking very seriously at the moment, both a drug that may suppress tinnitus, so stop people acquiring it in the first place, and also are looking at, sort of other therapeutic compounds as well. So it'll be interesting what they come with next. And of course, the team at Pittsburgh now have a drug as well that's, they've now got Department of Defense funding to start the animal trials and the animal work. So again, I think that'll be exciting to watch where that goes. I'm not sure we'll hear much about it in the next couple of years, but hopefully they'll be publishing towards the end of that and their animal work.
Again, with the DoD being involved, you'd like to think it would be fast-tracked, that it's not something which is going to sit around and have years and years and years. It was, in the spirit of the size of the problem that they're facing the veterans community, you hope that this is going to be pushed forward and it's something that they can actually, that gets out there within a couple of years.
Yeah, well, I mean, at the moment, it looks like they've got a 3-year grant to do animal work, for what I can figure out. So phase 1 trials, assuming that's successful, then, they'll need a phase 2 trial and 3 and 4. So it's something that it's hard to fast track. I mean, drug development does take sort of 8 to 10 years. Yeah. And actually, that's something else that pharma was saying to us was, well, what we need to understand is, taking the drugs work out of it, what will the tinnitus treatment and tinnitus management world look like, not now, but in about a decade? Because that's, what you're looking at for some of the drug development work from preclinical to going out. And, it may well be different for the Pittsburgh team, because obviously that's a drug that has been on the market previously and has been modified. So, I don't fully understand what they need to do if they're just looking at safety profiles for that and getting a more, an enhanced safety profile for that drug, or if they're doing something, much different. But it may well be faster. But a lot of the work is around just trying to understand that type of process and where we are, in terms of how long a drug takes to run through a pipeline. Yeah,
because again, you look at sort of therapies which you wouldn't think would be a curative, and again, look at it, think something like Neuromod. A company like that, a private company, can move quite fast.
Yeah.
And the drug development, if they're thinking, well, hang on, if they're doing that, and if bimodal stimulation, for example, turns out to be this amazing thing that you can, you're all of a sudden you're going to have the, you had the transcutaneal, which didn't quite. A few people try to do that as sort of a homemade version of it, and it didn't quite do anything. But when these things start to come out, people start experimenting and think, well, if you can do it like that, I wonder if I can access the brain by stimulating this nerve. I wonder if I can use this piece of sort of $20 or $30 kit to do this at home, and you kind of get all that experimentation. And if it does prove to be what we hope it could be with the bimodal stimulation, or even in combination with other therapies, then in 10 years' time, it could be a vastly transformed field.
Yeah, absolutely. And, it's hard to say, because obviously we've been here a little bit in the past with things like acoustic neuromodulation, which had a huge impact on the tinnitus community. And, when it came out, the amount of questions we had on our helpline about it and, what it was, because, people just latched onto it. And so you do see these sort of products come out and launch, and it'll be really interesting to see if, Neuromod and the bimodal stimulation sort of people can get the papers and the research evidence to back up the product, really. But I mean, obviously the product development pipeline for something like that is shorter than it is for a drug, just for the safety reasons, really.
Yeah, and again, and this was something that was posted on the forum probably about 4 years ago now, and it was from FICAL by Alexander Shulgin, and it was what was it, MDPEA. Of course, he tried loads of compounds on himself and measured the effects, and in this it said, I think it was 200 milligrams. Nothing happened, and after 20 minutes, my tinnitus disappeared. And you're like, oh. But you can't just jump in and research MDPEA. It's not scheduled. However, apparently you can take a blocker, which would make it psychoactive. So as soon as you try to do anything on it, it would become scheduled. But you kind of think to yourself, it's a shame, like with an audio treatment, you can just go out there and say to somebody, what's that like? However, trying to synthesize a drug which potentially could be illegal, you probably do it in China and import it, and then God knows what you're getting into. But and then you end up with this thing which is really interesting, which you want to see somebody research. Becomes years of research and safety profile in phase 1, and the millions will just stack up. Whereas what you really want, which I don't advocate, is 100 or a couple of hundred of Alexander Shulgins just trying it out.
Well, and there are drugs that we do know work for tinnitus. So lidocaine, we know suppresses tinnitus temporarily until the lidocaine wears off. So we do know there are drugs out there that work, but the safety profile on lidocaine just means you can't do that, and also you're not going to go and get it injected. Lidocaine's the type of anaesthetic you have given at dentists. So it's nothing that you can take regularly, and it's got a real safety issue anyway. So there are drugs that are out there that we know have an effect on tinnitus, but the real challenge is how you develop that in a way that can have something more long lasting, and ideally something that's oral rather than needs to be injected as well. So there are drugs out there and compounds out there that we know work. It's then how you make them safe, or how you find a different way to deliver it that's going to be efficacious, really, as well.
And again, the Trobalt thing, all of a sudden it was this miracle thing, but the safety profile is horrific. It was it's withdrawn from the market. But it's not something that you could continue to take. No. And I think there was, anecdotally, it did actually wear down the effect over time anyway. But and again, that's what's being researched at present, looking at a modified version of it, acting on the potassium channels. But it's really interesting stuff, but if it's not safe, then...
no, absolutely. Yeah, so... and in terms of what's coming up next year, I mean, are you aware of anything, that's exciting you? What are you expecting to see in 2019 in terms of research?
I have to say, I'm an audio geek anyway. So anything, that's why the bimodal stuff really grabs me. I know we've already covered it, obviously, but anything like that. But there's nothing particularly coming up, but I have noticed more that people are interested in it. Bimodal is an interest in more than one way of approaching it, and I'm kind of hoping that follows into the future, that people start looking at 2 ways or 3 ways and combinations of treatments that actually could have much greater efficacy than when you just do it by itself. No,
I agree. I think it'll be really exciting to see Neuromod publish, which I think we certainly got to expect next year. I'm not sure what Susan Shaw's timeline is at the moment, whether anything's coming out from their centre. But again, you'd hope to see, because I know there is a trial going on. So you hope you'd see some results from that fairly soon. Another paper that's come out that I'm still trying to get my head around is one by Fatima Hussain, which looks at using fMRI to try and see if you can predict tinnitus, and it looks like she might have found a way to do that, so might have found a potential objective measure, but I don't understand the paper well enough at the moment, but again I think it'll be interesting to see what comes, because again she presented something interesting around that at TRI, and we should see some trials kick off. It feels like there's been a bit of a dip, I think, in tinnitus work, but I think with the Pittsburgh team and with autonomy, you will see some pharma work start again and sort of re-emerge. So that'll be positive to see. And I'd really hope that we'd start to see some papers emerge as well from the sort of the PhD groups. So both the ESIT group and also the TINACT group.
Yeah.
I mean, ESIT are a little bit further ahead, but
Yes.
some of that research could be really informative as well. So I think it feels like we should start to see quite a bit emerge over the next sort of year or two. And alongside that, I know we're focusing on cure, and rightly so, but there'll be a lot of research around management as well, with the publication of a number of Cochrane reviews, which helps give us that high level of evidence as well. So it'll be good to have that out there and have that real sort of pinnacle, if you like, of the research at the systematic review level.
Yeah.
And again, that'll give the basis and the argument for future research to happen as well. So where it does say more research is needed, then the scientists, if you like, have got the justification and the cause for that.
Yeah, and I think with the stuff that you've been pushing recently as well, with the cure map, the cure roadmap as well, and kind of highlighting that a lot of the management techniques are pretty much researched, everything's in there. There's still an importance to them, because there's a sort of attitude, and I totally get it, of, well, we want a cure. Why are we interested in something that might help manage or might help this? But it's I think they're still really important, because you've got to understand the things that you can do to help you. And for some people, they actually will help a hell of a lot. They'll get really good results. But the thing, the feeling, and I totally get it as well, is that, if you've got all this management technique, why bother researching a cure? You want people to research the cure. You don't want them to think, oh, well, it's all right. People are happy enough.
Yeah, and I don't think that's happening. I mean, what we've discussed around some of the pharma investment that's going on, shows that people still want a cure. And, one of the reasons we did the economic paper a while ago was to try and show, that there's a market there, that there is management available that works for some, but not for everyone. And actually, this is sort of the cost, and this is the benefit, if you like, that people get in a measure that the NHS accepts. So we got that, but actually what that does do then is say, okay, so if you can develop a drug that works and, delivers a better outcome, then actually you're going to smash through the targets we're saying in terms of, what we can deliver at the moment. And I think the other thing with the management research is that it can inform the cure-based research as well, because like say, management research, you look at CBT, there's a lot of papers on it, but you can then go back through those papers, and maybe going back through those is one way to start to subtype, because all of a sudden you've got big numbers of people in a lot of trials, then maybe, you can use it. So I wouldn't necessarily see it all as either competing or separate in terms of the cure research and the management research. They both inform each other, and often you see, people and teams working across both. So, it's not just that one happens in isolation to the other. I think they do inform each other quite a bit.
Yeah, and I think the other thing as well with that is that the management techniques that we've got, and we often talk about, they often work for 30% of people. It's that combination again. If you've got a treatment which has got a reasonable efficacy, combining it with something which is already proven and validated as a management technique, finding that right technique for the individual and then combining the two is going to have much greater effects.
And I think that's what you see a lot. I mean, when bimodal stimulation is on the market, for instance, I'd be surprised if there's not a psychoeducation type of component to that. So you are actually using something that has some efficacy as well as the new device. So you do see those blended approaches. So, even if you do have something that becomes that, something that you can manage tinnitus with much more effectively than, you can with the standard stuff, I think they'll still blend those existing things that we know are out there as well.
I think we'll, because no matter, especially when you're in the early stages, I would say the first maybe year, 2 years, I don't know how long it was really with me, but in that early stage where things spook you and you're tense, you're up high, your reactions are just like, oh, God, I can't believe I've been to this place, I've damaged my ears again, I've made a mess of things, the tinnitus is going to get worse, and all these things that play through your head, actually learning to manage those reactions are probably going to be a really big part for people in the early stages who are getting treatment which otherwise would help, but they could throw themselves out of it by kind of falling into those thought patterns.
Yeah, because I think you're right. I mean, how do you engage constructively with the treatment if you're still in that sort of cycle? And I think there is a bit of, you still need that, like say, psychoeducation almost, that what is it and what's going on to almost help do it, and that does form an active part of treatment, I think, for a lot of things. So So yeah, whilst like say we've got that happening, it's I don't see it as that link. And I know, you know, the BTA takes criticism because we've supported CBT trials, but yeah, at the same time, they do inform other stuff as well. So it's not they happen in isolation. They get presented, and one of the reasons we have is because both the trials we have been decent high level RCTs, and you know, that's something that's lacking in the field, is that real research rigor at times, because you do see so many studies done on small numbers of people, protocols tweaked a little bit, and they do the same study almost again on a similar cohort, and you do need that rigor that's sometimes not always present, I think.
But again, leading on to something else that was presented at TRI is all the Comet ID and that development of the outcome measures. So we're actually, everybody's singing from the same hymn sheet, and we're not getting trials that say, yeah, well, we've done this, and you kind of, let's say if you're trying to do a Cochrane review, you're trying to combine, say, 300 trials, and they've all got these hugely different measures, they've done things in different ways, and it's just, and I understand that, how confusing it is. It's a desperate thing to have these measures through Comet ID. I mean, I was part of the panels. I went to the just around the corner from where I live, which was very handy, to the actual discussion day, and it was good, you know. And I won't say that I agreed 100% with the things that came out of it, but that was the whole point of the process. It was consensus, and everybody, you know, from this huge number of people that started off, hundreds that started off, it gets whittled down to the measures that we feel are important as patients, and then clinicians felt were important professionals. And it was really good to actually get these outcome measures, because, you know, if you ask any patient, what do they want? They want it loudness. You know, that's it. It's loudness, you know. It's there is nothing else that matters, and which always becomes very difficult because, you know, you get told with a lot of therapies that loudness doesn't matter. Well, ask any person, and it does. You know, that's the primary concept. So loudness was always going to be there, and I don't recall fully the measures that we came out with, but it was quite a satisfying process to say, oh, great. So moving forward, now I don't know how well people will adhere to it, but I guess the danger of not being considered high quality research if you don't.
And I think it's, you know, the questionnaires are still some way off, because although they've got the domains for drugs trials, sound trials, and psychological approaches, they still then need to develop a questionnaire to measure the domains that they've come up with. And I think it was tinnitus intrusiveness that was the one across all three that was seen as critical. And I know tinnitus loudness was included in the drugs trial, because the theory is that if you develop a drug, you want to obliterate the tinnitus, whereas, you know, psychological approaches aren't necessarily about reducing the sound, but reducing reaction to sound. So we're looking at slightly different things, and you know, it'll be interesting to see where they go. I know the Nottingham team have put in applications to develop a questionnaire in one of the domains. I think it might be sound. Not sure though. So, you know, they are looking at how to take that work on now, and it will be interesting to see. But again, you know, questionnaire development, you know, it takes time. You've got to develop a questionnaire, you've got to validate it, and, you know, it's again, sadly, you know, years of work. And, you know, that's why everyone was so hopeful that the TFI would be, you know, the saviour, if you like, for subjective measures in tinnitus. And whilst, you know, it's probably the best that's out there, I think, you know, most people agree on that. Sadly, in a UK population study, it kind of had issues. So that's a bit of a challenge. And one reason why Committed is now out there, I think.
Yeah. Well, again, I mean, I'm quite interested in the questionnaires and research and understanding more about sort of populations. And yes, and I think before I got involved with that, I had zero appreciation for how long it actually takes to get these things validated. You just think, well, you know, for what we could do tomorrow with what we do at Tinnitus Hub, right? Got a questionnaire? Yep. We'll get it written. We'll get it out there. 3 weeks later, it's out there and it's gathering things in. But of course, we can do what we want. You try and base it, but then of course you get them and you try and base it on already validated measures, and you try and kind of, well, we'll use that from that questionnaire, we'll use that from that questionnaire, and try and kind of make sure you're using the same scales and you're measuring the same things. But it's very difficult, because a lot of the things you want to measure and you want to ask, there's no validated measures for.
No, and I think, as soon as you do sort of cherry pick like that, the measure that you then create isn't being validated.
Yeah.
so you run into different troubles as well.
Yeah.
But and I agree, because obviously the BTA does a lot of surveys. We do a lot of work as well in similar ways, and it's that challenge, because as soon as you present at something like TRI, they want to see that you've used an outcome measure that's accepted.
Yeah.
And the story I always look back at is I do a lot of work. Sort of training audiologists every now and then, and one of the papers I use to train them is a paper on laser therapy. And basically I ask them, well, what does this paper show you? And actually, if you read it at face value, it shows you that lasers are great, they work really well. But then you say, okay, so have they used a validated outcome measure? It's no, they've designed their own Likert scale, and it's just stuff like that. And actually, once you start to look at it, the reasons you need those validated measures is if you don't, then it's easy to say that something's clinically, measured and clinically, works clinically. Whereas actually, you dive down and the validated outcome measures haven't been used. You look at where it's published, you look at the methodologies, and that's where you start to really understand a little bit more about how much weight you give to that piece of research, I think.
Yeah, and I think, again, that's something that you don't appreciate until you actually get into it. It was, I think, the first book that I read, Bad Science.
Yeah.
And that kind of I read that cover to cover in no time at all, and it was just massive eye-opener. You're like, whoa. And then you you go back to the sort of kitchen table discussions, if you like, and you've got them going, oh, well, tomatoes are good for you this week, and then you're bad for you next week. It's like, no. They're misreporting the trials, they're misreporting the outcome. They've cherry-picked one tiny little bit to create a story, and you try and explain it to your parents, and they're just like, oh, yeah, they change their mind all the time. It's like, well, that's what science is. It moves on all the time, but... and they say about the measures.
And I think that's one of the key things, because, the other thing that's going to come up soon is practice guidance on tinnitus through NICE.
Yeah.
And I think I saw the hearing loss practice guidance presented recently, and Kevin Munro from Manchester presented it, who's a fantastic professor based there. And he sort of gave a really good example of using that actually the reason we have guidance is because science changes, and that, your knowledge changes. So, like you say, one thing that you thought was efficacious almost might be disproven 3 years later. So you have practice guidance, you update it to reflect what the science tells you at the time. So all they ever are is a snapshot, but you just continue doing it. So, like you say, you get the eat 2 tomatoes 1 week and avoid tomatoes the next, and you try and get the consistency in there and try and get what science is telling you at the moment, because of course you hope it moves on in that frame and does tell you something different further down the line.
So coming back to the economics of tinnitus and the work that you've done on it, or the BTA have done on it, and you've published it, is that published now?
Yes, absolutely. Yeah.
It is. Yeah.
So
It took a while.
Yeah. The publication was a challenge, but no, we've got it out there now, and there's also a accompanying paper to it which looks at the sort of patient flow through the NHS as well.
So on that, you've looked at what the cost is to the NHS. Is it the cost of the patient going through there? So what's the hope of the outcome of that? Is that to convince the NHS that it's worth treating tinnitus?
Yeah. I mean, the absolute headline for us through that paper is that actually tinnitus management, as it stands at the moment, is cost effective, using the benchmarks that NICE accept and the NHS accepts. So looking at cost of per quality, so per quality of life year adjusted life year. So that assumes that you get a small incremental improvement in your quality of life for a number of years based on getting successful tinnitus management. It assumes that not everyone gets that. It assumes, I think we put about 20% of people at each step, so it's quite conservative. Improve. But if that happens, then actually, the headline is that tinnitus management, as it currently stands within the UK, is cost effective. So that was our primary aim, not to demonstrate that, but just to understand if it is or not. We published all the papers, and we published the Excel spreadsheets we used to calculate that as well, or the health economist used to calculate that. So again, we made them available so that commercial companies, pharma, can play with them, can put in their own treatment and put in their own cost of that to the NHS, and put in what they believe is the efficacy of it and see if their treatment comes out as more or less cost effective than what exists. What we did show was that actually if you go to your GP and your ENT and you're discharged at that point, that's not cost effective. And a lot of people seem to have that. So you have 2 diagnostic interventions, but no actual management or no sort of input in a way of, how to manage it, no basic psychoeducation. So that was very costly. But actually, GP to ENT to audiologist, or even, for the few people who get to psychology at the end, that whole pathway through sort of 4 different levels is cost effective as well. So that was positive, and we averaged the cost. I mean, it's been a while since I've read the paper now, but the average cost per patient is just over £700 to the NHS, which includes things like hearing aids, which you can argue is not just to treat the tinnitus, is to treat underlying hearing loss as well. The majority of the cost in that is doing the diagnostic tests. So we estimated that 50% of people with tinnitus will have an MRI scan, and that is the biggest cost element of that of the whole pathway is the MRI scan and the ENT appointment. So actually, a lot of the cost is in the diagnostic, in looking at underlying pathology. But once you get beyond that, it's not that expensive in terms of what's there at the moment, but also we're saying it's not that efficacious either. So there is room to improve it if people come up with better ways to manage it or better ways to obviously cure it as well. Especially if it's a pill and you can deliver that at GP level. It's incredibly cost effective. So there's real benefits in what we've done there. What we also came up with was a cost to society. So we estimated that tinnitus costs UK PLC over £2 billion a year in lost time at work, in people retiring early, in relationship breakdown, in loss of sleep and general loss of productivity. So there's a huge underlying cost to the UK as well. It's actually a bigger cost than the cost to the NHS of successful treatment as it stands at the moment. And some unsuccessful treatment. So actually, again, if we can show that there's a better treatment out there, you can show that actually the saving to UK PLC is going to be quite impressive as well and will make a difference. And all of our figures, you can criticise and say they're conservative because we don't take into account the impact on carers or loved ones or people around that person.
What about comorbidities as well? Because you've got, say, stress, anxiety, depression, I would say, were the most common comorbidities that you would be going and getting concurrent treatment for. And he said the first big piece of research that we did was around asking people about that, and I don't know the figures off the top of my head. There's a significant amount of people who asked them, did you have this before tinnitus, did you have it after? And stress, anxiety, depression, that all, not everybody, but there's a significant amount of people reported that, reported panic attacks, and you think then you've got another GP visit, you've got drug treatment, you've got whatever it is that they actually have to treat you with, and then how many visits to, some people they'll visit A&E, or they'll go through the system again, and there's a lot of associated cost.
And we included that in the sort of 2 billion societal cost. So we included it there, but our modelling wasn't sophisticated enough to look at those additional costs to the NHS in terms of mistreat or untreated tinnitus, or just tinnitus that wasn't successfully treated. We didn't include it in the cost of the NHS, but we did include it in the societal costs. And again, we've been really honest about what that paper is. It's a start of a conversation, really. It's it's done based on expert opinion in terms of we had a group of people around a table who looked at what normal treatment looks like, and we used costs that were available to us, and then we also did a patient survey as well. So it's certainly not high level evidence, but it does give you those benchmarks, and based on what else is out there, it's a pretty robust study in terms of what else we've got looking at the cost of tinnitus. There's a study in Holland, and there's one in the US as well that we used as comparators, and we're not far off what they came to either.
Again, making that business case for it is another thing which the NHS, I mean, we're relatively unique, aren't we, with having the NHS in this country, but outside of that, the private healthcare is going to be even more interested in the fact of all right, well, I'm not going to spend this pot now if I can spend this pot now. And treat people up front. So I guess it's a broader perspective of trying to actually, and once you start bringing the the cost into it, then you can kind of think, all right, well, let's look at what treatments there are.
Yeah.
And if they start looking at what treatments there are, it brings more people in the marketplace, and it's kind of that knock-on effect, isn't it?
Yeah, absolutely. And, like I said, the intention of the piece of research was to understand if, what's out there at the moment is cost effective. But the other thing it does is, we're disseminating that and made sure that all the pharma companies who are involved in tinnitus research are aware of that paper as well, because it is a big sort of green light. It says, go fetch. Here's the size of the market. Here's what you'd need to do to make your drug efficacious, and really trying to give pharma the tools they need to make the economic case in an independent way as well, because pharma can go do their own cost analysis, of course, but the challenge is that if they then use that for evidence to go to NICE, it's not independent, so they actually need that independent work out there. So again, it's not cure research in its purest sense, but it does help give pharma that playing field, if you like, to say, right, well, here's something else, here's another tool that helps us understand the market and what we need to do to get there, or Neuromod or anyone else. And again, that's what we've looked to do with the Cure Map as well, is just try and plot where research is, so people can have that overview and understand where we're at, and also what the challenges are, in a way that just establishes that. So everything that we're trying to do at the moment is provide tools that we've been told that industry and pharma want to be able to look at tinnitus research more seriously.
Yeah, and I think for me as well, just touching on that, it's good to see BTA moving in that direction. And like you say, there's plenty of criticism in the past about, well, you're funding this, you're funding that. And I mean, you don't really have a big funding pot, do you?
No.
In terms of...
No, exactly. I mean, the money we do put in isn't going to support a phase 2 clinical drugs trial. We're just not at that level. And, what we do is some of the basic science that might get there. And then, like you say, a lot of the management research, which, fully understand and accept gets criticism. But, at the same time, it's... if we can make a difference to people's lives in a couple of years through doing that, whilst also hopefully helping pharma to get the right tools to do it, then we'll look at that. And we are moving a little bit more towards the curative side of it as well, and trying to challenge research to get there. But yeah, at the same time, in the past, we've certainly looked at how we can make a difference with what we have available.
Yeah, exactly. From looking at it, it's great. You got the Cure Map. And where does it go from here? Is it kind of like trying to bring people into... Because I guess the only way you can do it, unless all of a sudden people develop shallower pockets and longer arms and start giving reasonable amounts of money to actually support tinnitus research, which massively under-supported. Let's say your budget's kind of like it's never going to make an impact. I guess the whole thing is to try and encourage funders and donors and research partners, and kind of, like you say, making that case, and then just say, right, look, here you go.
Yeah. No, our strategy is going to move to look at how we can work on projects that we think are important, but then, like you say, approach those bigger funders to see if they'll invest in those projects as well. So doing things like the Cure Map, the economic paper, we'll have a paper out hopefully early next year, which kind of covers a lot of the ground that we discussed here, actually, in terms of some of the challenges that are out there. We really hope that just builds a case that we can go to some of the bigger funders and say, look, here you are, consider investing in tinnitus research, here's a portfolio of where we're at, and this is what would make a meaningful difference. And so what we're looking to do as a charity from here really is look at how we can start to support research that systematically gets us to a cure. So, we're not obviously going to stop, or we're not going to influence people who are already doing that research in terms of looking for a cure, but actually, what can we do to, help better understand if there is an objective measure? What can we do to help subtype tinnitus? What can we do to really answer some of those fundamental questions that might help us understand if cures are already out there, or to really give pharma those tools that help them invest more in the future as well.
Yeah, because you look at the average, and I'm quoting in dollars, but I think, is it a phase 1 trial is about $1 million.
I'd imagine it's about that. I mean, Pittsburgh have got, was it 1.2 million for theirs?
Yeah, I think I think their original budget was $1 million, but 1.2, and that for a phase 1, just a safety trial.
Yeah,
I mean, that's just way outside the reach of what you can lay your hands on. So I guess it's trying to lay groundwork for that, so these people can actually say, "Oh, great! Well, we may be able to fast track. We know we've got a market, or we know we can spend that money with greater confidence."
Absolutely. So ideally, they know there's a market there, so they don't have to do the initial market research, which saves them a few months. You know, so there's things like that I think we can do that helps those audiences, and it's about making sure then they know that's available, and the more we can do that, hopefully, the more it just looks like tinnitus is a field that's professionalising in terms of research and is worth investing in as well.
Yeah, absolutely. Well, I think that's grand. Thank you very much for coming along, and hopefully that's been useful for the people watching, and thanks very much.
Yeah, and I guess there'll be a strand on this somewhere, and happy to engage with it to a level as well and answer any questions that come up.
Excellent, thank you. Cheers.
Pleasure. Thank you, Steve.